Now I'd like to introduce Dr. Conley, who will be speaking on the topic of biomarkers in sarcoma. He's a medical oncologist and associate professor specializing in sarcoma at MD Anderson. Dr. Conley's goal is to provide the best possible care for sarcoma patients. His clinical research interests involve chordoma, chondrosarcoma, rhabdomyosarcoma, malignant granular cell tumors, and gastrointestinal stromal tumors. Thank you so much, Dr. Conley, for joining us today, and pass it on to you. Thank you.
Okay, great. Hi, I hope everyone can hear me okay. If not, please let me know. And I'll go ahead and share my screen. Let's see here. All right. Hopefully it looks okay. If there's any issues, just let me know. I'd like to thank the Alliance for allowing me to have the opportunity to speak with you all today. I was looking through some of the names and I recognized some folks. Hopefully you'll find this helpful. And just so you know, even though I do research in certain areas of sarcoma, I take care of any patient that has a sarcoma that's in need. And so today I'll talk about biomarkers in sarcoma. So I usually like to divide these into several sections, such as defining what biomarkers are, talking about the tools for biomarker detection, talking about how we use biomarkers to sometimes select out treatments. And then I think the more recent development is the use of blood biomarkers for a variety of different issues that we do in management. And then we'll just kind of conclude things, and then I'll be happy to take any questions that you may have. So I'll start off by talking about the NCI, or National Cancer Institute, definition for biomarkers. So essentially, a biomarker is any biological molecule found in blood, other body fluids, or tissues that can serve as a sign of either normal or abnormal processes, conditions, or diseases. Sometimes we can use biomarkers to determine how well a treatment may be affecting a condition. And importantly, there are certain interchangeable words to know about. Sometimes in your reading, you might come upon molecular markers or signature molecules. These are all basically biomarkers. And I think the classic example that I think about in terms of biomarkers in cancer medicine in general would be prostate-specific antigen, or PSA, for prostate cancer. High PSA levels in the presence of having a prostate cancer can sometimes help clinicians to alter treatment plans for their patients. And so that's an example of a biomarker. Now, importantly, there are many different types of biomarkers, but I think the ones that are most important for us to think about today would be kind of simple three: diagnostic, predictive, and prognostic. So diagnostic biomarkers, basically any sort of marker that allows us to help confirm or detect the presence of a disease or condition. So sometimes when a pathologist, which are the physicians, of course, that make the tissue diagnosis, when they're looking at the slide, they may have an idea of what the disease is, but sometimes they'll use different types of technologies to confirm the results. Those types of tools can be detection of biomarkers that will help aid in the diagnostic approach to their management. Predictive biomarkers, a little different. Predictive biomarkers help us to understand how well something may or may not work when a patient is exposed to a medical product or environmental agent. And then lastly, prognostic biomarkers are essentially biomarkers that help us to identify the likelihood of a clinical event. Sometimes we look at them as ways to help determine risk for patients. So if a patient's had their tumor removed from their body through surgery, are there biomarkers that we can use that can help you understand what your risk of relapse is, or the risk of a patient developing distant metastatic disease? And so that's kind of an example. And I'll kind of give a few examples through the talk. And I think in that regard, there's three big tests that I think it's important to understand, two of which have been around for a while, but I bring them up because they're always seen on pathology reports. So if you take the time to look through your pathology report, sometimes you'll see a number of different things that are written in there. And so one of those is immunohistochemistry, or what we call IHC for short. Another is fluorescence in situ hybridization, also known as FISH. And then there are the more recent molecular strategies like next generation sequencing, which can be done from either solid tissue panels from biopsy tissues, surgical tissues, and now even fluids like blood-based panels. So with IHC or immunohistochemistry, think of it as a way or tool for pathologists to detect the presence of proteins on the surface of a tissue sample. So they're looking at slides. Again, importantly, pathologists don't just make the diagnosis because of a biomarker alone. And I think that's one thing to understand. It's really important. Sometimes medical oncologists seem to forget this as well, that these tools help the pathologist to make the diagnosis, but the diagnosis comes from the years of experience of looking at the tissue characteristics over and over and over again. And so it's the morphology or the shape of the cells, the patterns they see on the microscope that helps them to arrive at their diagnosis. The immunohistochemistry or IHC helps them to confirm or refute the diagnosis that they're thinking about, either because the sample is expected to have a particular type of protein or not. And so the way this works is it relies on two antibodies, of what we call primary antibody and a secondary antibody. The primary antibody is one that is being used to detect whatever protein is that you're looking at. So a classic example would be, let's say, a GI stromal tumor that's KIT mutated. So usually in GI stromal tumors, we would expect to see lots of KIT protein on the surface of the cancer, right? So they'll have an antibody that will detect or attach to any cell that's got KIT on its surface, but then they have a secondary antibody that attaches to the first and is color-coded, and so that gives color. And so, basically once they have used their immunohistochemistry on the surface of the slide of the tissue sample, then they look at it under the microscope to be able to identify what they're seeing. And so here, oftentimes the markers are color-coded in brown colors, and that's just what has been chosen over the years. There could be more to it than that someone like Dr. Lazar or Dr. D'Amico could expand upon. Now, importantly, there are both advantages and disadvantages to IHC. This is a representation of esophageal tissue, so it's not like a tumor. It's just to kind of show you the difference. So normally, when the pathologists stain tissue samples, they're using what we call an H&E stain, hematoxylin staining, and so it usually gives. There's slightly different colors. Some will be in pink, some will be in this blue color, and then below it is an antibody to TP63, which was the protein that this diagram was going to use to show you the difference. And what you see here is that this protein is color-coded in brown. So it's showing you not only the presence of the protein, but where it's located on the surface of these cells. So the advantage to IHC is it's been around for a long time, so it's relatively inexpensive. Because it's been around for a long time, there's a very rapid turnaround time because there's lots of technicians that know how to use this technology. There are an abundance of probes that can be used, so you can name just about any protein you want. There's probably been a probe made by a company for this context. And then there's what we call multiplexing. This is basically where there's technology that can do multiple stains at once. So in the past, it was just you had to do your one stain at a time, and that could be time consuming and it could use up a lot of tissue. Now you can actually do 16, 32 different probes at once, and so you get sort of an assortment that the pathologist can use to identify patterns. The disadvantage is that just because a protein is found on the tumor, the cell that you're looking at, doesn't necessarily mean it's specific for it. There could be other tumors that share that protein. And this is why I say, IHC can be helpful, but it shouldn't be the only thing that pathologists use to arrive at a diagnosis. The other thing is that these antibodies are not always super specific for one protein. Sometimes you can get a false positive because another protein causes that antibody to bind to it erroneously. And then lastly, there's standardization techniques. There's lots of different technologies to look at this. And while there's a lot of consistencies in some countries, you may find that in others, if there's not sort of a credentialing process to ensure standardization, that could, of course, pose a problem. Classic example, here's a tumor called a solitary fibrous tumor. On the left, we have the classic H&E stain, and so the pathologist would look at this. They would look at the characteristic thin-walled blood vessels. They would look at the patterns that the cells have, but then they would say to themselves potentially, okay, I think this is a solitary fibrous tumor, but let me use a stain that will help make that diagnosis. And so, for instance, STAT6 is a stain that has been developed as a diagnostic to aid in the diagnosis of solitary fibrous tumor. And in this case, the sample shows this deep brown staining throughout the slide, indicating that STAT6 is present. And for the pathologist that's interested, it helps to confirm their diagnosis. So that's how IHC is typically used, okay? Next, we have FISH. Sometimes you may see FISH reports on MyChart if you use MyChart for your healthcare needs. But FISH stands for fluorescence in situ hybridization. And the schematic on the right is somewhat complicated, but essentially what it's getting at is that there are probes that can be used that can flank each side of a gene of interest. And then the probes actually can be colored. And so essentially what happens is that, let's say we're looking at a particular disease that has a gene that should be present. The FISH will help you the FISH for that particular gene will help you determine if that particular gene is present in the sample, because once the whole process is carried out, there should be colored probes that you find on the slides once you use the correct type of microscopy. Now, the advantage is that it's super duper specific and sensitive. So if you're looking at it, because genes have all sorts of different nucleic acid codes, these probes tend to be very specific. They can be used to detect what we call amplifications, which is where you have too many copies of a normal gene. It can be used to detect translocations, which would be essentially where you have two genes that abnormally fuse together. And then lastly, it can also be used to detect gene deletions or the absence. It's highly versatile. You can use it in both solid tissue samples as well as fluid samples. It can be a great way to visualize the genetic material, fast turnaround time because it's been around for quite a while. And again, the availability of probes are high because there are a number of different companies that market their products in this space. The disadvantage is that it's limited information, right? And you're using a tissue for that limited information. And now there are more technologies that can get you much more information with a smaller piece of tissue sample than what FISH can get you. And again, importantly, as a medical oncologist, I don't want to speak for the pathologist. And there's newer forms of FISH that are in development that are probably way better. But in terms of just the general take on this, I just wanted you to understand what the basics would be regarding FISH. And this is an example. So for instance, Ewing sarcomas are typified as having a very peculiar appearing pathology. They're usually small round blue cells that have really big nuclei, very small cytoplasm. But there are several different tumors that can have that appearance as well. And so aside from the clinical context, such as knowing that it came from bone or knowing the symptoms that the patient had a diagnosis, the other factor the pathologist can use is to determine if the sample has the fusion protein, which is found in Ewing sarcoma, which is EWSR1 Fly1. There's actually several other Ewing sarcoma variants that will have EWSR1. And so the probe can be, what happens is the pathologist would use the probe for EWSR1. And here's this kind of the schematic from an older paper that Dr. Alex Lazar, one of the pathologists, published years ago. And essentially what he's showing here is where the probe would technically be. And here are actually Ewing sarcoma cells where the colored probes are noted. And so when they see that under the type of microscope they're using, then that helps them to arrive at the diagnosis of, yes, this is Ewing sarcoma. So that's how FISH is typically used. And I say that because, again, this is something that is frequently found on pathology reports. So if you're ever wondering what FISH relates to or immunohistochemistry relates to, these are sort of the basics behind that. Now, and of course, about 40% of all sarcomas are translocation driven. So these types of FISH technologies are great for looking at the common types of sarcomas. One of the disadvantages to this technology is that unless you have probes for the really rare things, it can sometimes cause the pathologist to not arrive at the right diagnosis, especially if the tumor looks very, very similar in the microscope. And that's where other more recent techniques like RNA sequencing has become popular because it's a way to sort of catch these lesser common fusions that you wouldn't be able to detect through the typical FISH probes that your pathologist would have. And this is even in the biggest center. So it's not just because you wouldn't have it in your local, oncology, pathology setup. It's because the same issues can arise whether you're in New York, Boston, LA, or other places like Houston. So that's just an example there. But now I'll talk to you about next generation sequencing, or NGS. And that, of course, is a technology that's been around now for a few years. we've basically had it now about 14 years now at least, and it's been getting better and better and better. The NCI definition for next generation sequencing is essentially a high throughput method to determine a portion of nucleotide sequences of an individual's genome, and it's capable of processing multiple DNA sequencing in parallel. So what does all that mean? It's basically a way to extract DNA, and then using a type of technology where you build out what we call a library of DNA fragments. We then can sequence them out, and then we have a computation that will analyze the results and basically provide us the data in certain ways. I think the most common type that you see are what we call targeted gene panels. So I'm sure some of you have been exposed to Foundation Medicine, Tempus, Boston Gene, there's Predicin, there's a whole host of different companies that are in this space, and they use panels that usually have a set number of genes in them. Now, the plus is that they'll usually be common genes in cancer. The negative is that if it's a sarcoma, it may not always be included on that panel, since unfortunately a lot of these panels are geared towards the common cancers like lung, breast, prostate, colon. And so this is where it's nice to have more expanded panels, such as through exome sequencing, which is another form of next generation sequencing, where now we're looking at all genes in the human genome that result in protein expression. And so now we're talking thousands of genes. And then lastly, there's whole genome sequencing, where we're looking at the entire genome, all the DNA strands that tissue sample of interest has. And so you can get a lot of information. There's downsides to each. The targeted panels, again, limited set genes, but it's a rapid turnaround time, not very expensive now because it's so widely available. Exome sequencing, a little bit more time consuming, a lot more data about genes. And now you have to have folks that specialize in analyzing the results to ensure that you get accurate results. And then the whole genome sequencing is probably the most expensive, most complicated type. But even that is becoming commercially available. The issue becomes, what do you do with all that information? Sometimes we'll find interesting information from it, but we won't have any context in how we can use it for clinical care. And so that can be one of the limitations. Though I think all of these factors will sort of sort itself out with time. So eventually it'll become something that is very routine and easy for us to be aware of and to use in patient care. Now, this is a study that was published by Dr. Ben Nassif, who I think he's now at Pittsburgh, but he trained and was faculty at Memorial Sloan Kettering for a few years. And here is sort of a schematic or diagram looking at the many different types of sarcoma patients that they did sequencing on using a panel that they have at Sloan Kettering called IMPACT. And if we look at the right here, it may look a little complicated, but what he's done is he's looked at, if we look at the left side of this diagram, he's got these different genes. So like TP53, what he's saying is that all these tumor types right here have a certain degree of TP53 mutations present. So this x-axis here is kind of telling us what the percent is. And so for instance, LMS, it looks like 45% of the samples that they tested had TP53 mutations, whereas osteosarcoma was only found in 26%. Now, the pitfall to this is, again, these panels sometimes vary. Sometimes these targeted gene panels don't sequence out the entire gene, they just sequence out portions. And I say this because, for instance, osteosarcoma is a disease where nearly 100% of osteosarcoma patients will have a TP53 mutation in their tumor. But some of these panels may not be detecting the entire gene. So if it's only detecting portions of it, it could be totally missed. But the point of this is just to kind of show how there's many different genes that can have importance for many different types of sarcomas. And these panels continue to evolve, so I'm sure that the IMPACT panel that Memorial Sloan Kettering uses today is probably more advanced than what was being used for this publication that occurred a few years ago. So importantly, again, so why are biomarkers important for sarcoma patients? One, because they can be diagnostic and help to arrive at a diagnosis. Two, it can give us prognostic information. Sometimes patients for a certain disease may have a TP53 mutation that has no relevance to the disease. And yet for other sarcomas, having that TP53 mutation may tell us that, okay, your risk of having a relapse is much higher, therefore we need to modify how we're watching over you. So that's where prognostic biomarkers can be handy. And of course, now there's treatment selection, right? So using a targeted approach for selected FDA-approved therapies, a targeted approach for selecting out non-FDA approved but NCCN recommended therapies, and then sometimes targeted approaches for clinical trial selection. And importantly, context is really important. Just because you have a biomarker that can select out for therapy doesn't necessarily mean that it's more important than the therapy your oncologist may have you on. So there's all these nuances that sometimes get lost. And that's why I would also caution in over-interpreting these results that you get, because sometimes they'll, like, I've seen where some of these reports will say things like, superior response expected. And I would say, I would caution, I think it really depends on the context. And that's where your oncologist can hopefully help walk you through these reports. And I would say that if you have an oncologist ordering this test, you absolutely have a right as a patient to ask them to sit down and explain it, even if it means perhaps even another visit, another MyChart message. But it's important because it is part of your care, and it may drive where you go with your care in the future, right? So importantly, this is a little bit of a busy slide. These are the current FDA-approved targeted therapies in sarcoma. It's nice that we can actually fill up a page. To be honest with you, I would love to see many more pages filled up with these types of agents. And unfortunately, what you'll see is that there's a predilection of these agents for certain types of sarcoma. So obviously, for patients that have gastrointestinal stromal tumors, the only therapies that have had any benefit at all have been targeted. The standard chemotherapies that might work for a particular disease does not seem to work for GI stromal tumors. And so we know that imatinib, sunitinib, regorafenib, ripretinib, avapritinib all have activity against certain forms of GIST. But now we have other ones too, right? So if you have an inflammatory myofibroblastic tumor that is no longer removable by surgery, these tumors typically will have ALK fusion proteins. As a result, crizotinib has been FDA approved for any patient that has an ALK fusion-associated inflammatory myofibroblastic tumor. For synovial sarcoma, there was a huge advance this year where there was the approval, and I apologize for butchering the name. I'll just refer to the last name, autoleucel. So basically, this is the T-cell receptor therapy against MAGE-A4, which is a protein found on the surface of synovial sarcoma cells. And because synovial sarcomas have tremendous expression on the surface for MAGE-A4, it became a perfect target for these T-cell receptor therapies. And so it's FDA approved for metastatic unresectable patients, unfortunately, that have a very specific type of white blood cell, which is only found in approximately 20% of Caucasians. So you can understand, unfortunately, it's great that we have this new therapy that's been approved. It's unfortunate that it's still not something that we can provide to all patients that have that disease. And again, just so you know, the people that developed this for synovial sarcoma weren't just trying to select out synovial sarcoma alone. I mean, if we could have this for all types of sarcomas, we would. It just so happened that that particular disease expressed it to a degree far greater than most other sarcomas. And so that's why the development was for that area. I would say, I would expect to see that in the next few years to decade, you will see similar types of approaches being carried out and approved for other types of sarcomas as well. NTRK fusions, 2 to 3% of all sarcoma patients may have an NTRK fusion, which makes you highly sensitive to entrectinib or larotrectinib. Both are NTRK inhibitors made by different sponsors and impart a very high response rate if you have them. For patients that have a high amount of tumor mutations, or what we call a high tumor mutation burden, pembrolizumab is now FDA approved. So if you have more than 10 mutations per megabase, pembrolizumab is approved regardless of the type of tumor you have. And then lastly, the other big approval that occurred earlier this year is the famtrastuzumab deruxtecan, which is essentially an antibody drug conjugate against HER2 protein, which is abundantly found on certain types of breast cancer. But as it turns out, any cancer that has high positivity of the HER2 protein now has an FDA approval for this agent. And so do all sarcomas have it? Unfortunately not. Some sarcomas have more than others, and they use an immunohistochemical stain, which is really easy. Most pathologists that have experience with cancer management or diagnosis would have access to this type of immunohistochemistry. So it is definitely a tool that we're now testing on many patients, because if you have that HER2 positivity, this gives you another option to potentially use to target your disease. Now, importantly, there are biomarkers for which we don't have any approved therapies, but are still very, very sought after at the moment. And importantly, this slide alone, I want to make a point that these are not the only markers that are of interest. I would say that these are the ones that are probably getting closer and closer to the finish line. But there are many more targets that folks are looking at in different institutions. But so, for instance, if it turns out that your molecular report shows that you have an ATRX mutation, there are clinical trials that are now available where we are using PARP inhibitors, a class of medicine that helps in disabling your cancer cell's ability of repairing DNA damage. So if you have the ATRX mutation, there may be trials that are available. Diseases where we frequently see ATRX mutations include sarcoma, UPS, osteosarcoma, but it's not just limited to those. There are others too. For about half of all conventional sarcoma patients, we have the IDH1 or 2 mutations that are present, and there are inhibitors that are in development for this disease. For the liposarcomas or endometrial sarcoma, there's the MDM2 amplification. There are drugs that are in development that target MDM2. For patients that have mismatched repair protein loss, immune checkpoint inhibitors seem to be an avenue by which these tumors will essentially respond. More recently, there's what we call MTAP loss, and this is a gene that's got a really long name, but the point is that if you have MTAP loss, there are studies that suggest that there are certain types of new and evolving therapies that may be active in this disease, such as the PRMT5 inhibitors or MAT2A inhibitors. Again, on the right, you have the list of sarcomas where we frequently see this protein expression of NY-ESO-1 or PRAME for synovial sarcoma. There's a small degree of sarcoma patients that will have ROS1 fusions, and there are numerous ROS1 inhibitors that are now on the market. And for patients that have this really specific type of TP53 mutation, the Y220C mutation, there's actually a drug in development called the P53 Y220C reactivators that are demonstrating responses in early phase studies. And again, context is important. Just because your tumor may have some of these factors does not necessarily mean that it's more important than the therapy that you're currently on. Sometimes these are factored in. Oftentimes we may have a target that seems interesting, but we still need to figure out what makes the most sense for that disease. But it is good to have, because again, when we're thinking about spreading our options and having more so we can treat these diseases, it's great to have these types of tools to identify these types of molecular targets. And then lastly, because I guess we're probably going to be running out of time soon, there are the blood testing, what we call ctDNA, circulating tumor DNA. This is where we're doing these same types of next generation sequencing, but from DNA that's circulating in the blood that is presumably from the cancer. And again, the idea is that your normal tissue shouldn't have some of these DNA mutations. So if they're found in the blood, and we know you've got a particular sarcoma that has that mutation, then we can assume that it's in the blood circulating. And that can sometimes give us information about prognosis, what we call minimal residual disease detection. Sometimes it can help out select out for certain clinical trials. And here are just 2 brief examples. I think the one that's closest to practice is the use of blood biomarkers for GIST. So, this was a trial that was published in Nature Medicine earlier this year for the INTRIGUE trial, Reprid versus sunitinib. These 2 agents in second line turned out to be somewhat equivalent, but it turns out that when you looked at their blood profiles for the secondary KIT mutations, some patients were better off with Reprid, while others were better off with sunitinib. And so now there's an ongoing trial to validate these results. And if it comes back positive, that means we'll essentially be using these blood-based tests to select out for better therapies after a patient develops resistance to imatinib, if they do. So it's a nice tool that doesn't involve repeated tissue biopsies, but we can sample the blood and now make treatment changes. Another one that I think is of interest is in rhabdomyosarcoma. And for those that have, dealt with this personally or have known people that have, obviously, it can be a devastating disease. And so there's different ways that we're trying to improve upon it. Well, this is a technology that was being used by the Children's Oncology Group on one of their trials, where they showed that when they did this ultra-low passage whole genome sequencing, if you had the fusion that's found in that disease at certain levels, it was able to predict for what we call event-free survival and overall survival. And so it's cool to see that this can be used. The problem is that technology has not made it to commercial setting yet. So, if a person with rhabdomyosarcoma sees me and wants this test, I still don't have the ability to order it because it's not commercial yet. This was one of the trials that helped to show that we can actually use fusion detection in blood as a way to give us information about risk, right? But again, this is kind of a way to show you that this is where the field is heading. I think many of you will have these tests done. And importantly, sometimes if your clinician doesn't do those tests, don't assume it's because they don't want to or they're not aware of it. Some context at the moment. I think if you're interested in this type of testing, be sure to talk to your oncologist about it to determine if it's an appropriate tool to use at that point in time. So again, biomarkers can be used for diagnosis, prognostic information, treatment selection, tracking progress of disease or therapies for a particular disease. And so with that, I'm happy to take any questions. I apologize if I went over time. And at this point, I don't know if I need to stop sharing or if we just ask away and go from there.
Yeah, thank you. Thank you, Dr. Conley. That was great. Now you're perfect, just on time. Yeah, so there's a few questions in the chat. I will read them off to you. Is it HER or HER2 testing standard of care in sarcoma, or is this something patients need to ask for?
A great question. I would say it's probably not standard. I'll put it this way. So it is a standard immunohistochemical tool now because it's been used for breast cancer management for nearly 20 years now, or actually more than 20 years. It is readily available. Because of this recent FDA approval, this test should be covered by insurance. There should not be a reason why insurance wouldn't cover it. It is not that expensive to do. But to your point, I think that there is still a learning curve, even among oncologists, as to when we should order the test. Ideally, it'd be great if a pathologist would do it, but they don't always do it. And I think part of it has to do with the billing process. And I don't mean that to be, it's just simply the way it is. It's the way Central Medical Services has regulated on diagnostic testing that pathologists do. So, and importantly, there are some tumors where we know there's little to no expression of HER2. So I would say that if there's an interest to know if your tumor has it, I would be sure to ask your oncologist, if it makes sense to check it for your tumor. But yeah, so that I hope that answered that question.
Thank you. Can you stop sharing? Because I think we're still seeing, okay, I think we're having a little issue. Thank you so much. Okay, the next question, and this may have been, this person might need to specify this because I think it was something I had up on the screen, but it said, would myxoid round cell liposarcoma fall under any of these types? I don't know if you know what she's referring to.
I think I know.
Okay.
Yeah, so myxoid liposarcoma is a fusion-driven sarcoma, and similar to synovial sarcoma, tends to have very high expression of some of these proteins that I talked about, this MAGE-A4, NY-ESO-1, PRAME. So while I mentioned that the development for those T-cell receptor therapies have been specifically for synovial, I can assure you that there have been studies carried out now for myxoid liposarcoma. I can't tell you where they're at in terms of how close they are to the finish line. I don't do consulting specifically for that. I have colleagues that have done more direct research in that area, but I can tell you that there has been work in that area. It looks promising. So hopefully we'll see that in the next few years. I can tell you there are already clinical trials that certainly that can be available for patients with myxoid liposarcoma, but we should see that this area is developed for myxoid liposarcoma.
Okay. Okay, next one. Where does a test like NATA, Signatera fit into this? Would a test like that make sense for a patient who's currently NED to establish a baseline or identify growing residual disease that hasn't shown up on a scan yet? And says example, DSRCT.
Yeah, so good question. So Natera, and again, it is a blood-based test. Now, what's different is this. So like when I talked about ctDNA, that's where, let's say you've got a chondrosarcoma and you've got an IDH1 mutation in the tumor, and we know it, right? We've already tested the tumor, we know it. Sometimes IDH1 mutation will be found in the blood, and you can detect it through the ctDNA test, and we can even quantify it. We can tell you what the percentage of it is in the blood. With Natera, it's a little bit different. They're not looking to tell you what genes are in the blood. They're just looking to tell you if there are circulating tumor cells. Now, I don't want to, I don't want to misspeak for Natera, but my understanding is that they have a proprietary process where they get a piece of your tumor tissue and they do their analytics on it. And then what they do is they take your blood sample and they seek to identify whether the markers they found in your tumor are also found in blood. And again, it's proprietary because they've got like a patent on it, right? But the point is that they're just trying to tell you whether there's tumor cells that are present. Having DNA in the blood from a tumor doesn't mean that there's tumor cells in the blood. It just means that there was DNA that was shed off of the tumor wherever it is, right? So that's a key difference. So Natera has been validated for cancers like colon cancer and breast cancer. There has been work presented in certain types of sarcomas. I would say the area where I've heard of it being more readily used is in leiomyosarcoma. And importantly, I'm not aware of any publications yet that have totally validated its use, but I know that there have been groups, I think the Toronto group is one of them that have presented some of their work at ASCO, the American Society for Clinical Oncology, and others, showing how a test like Natera could be helpful. So so I guess the bottom line is it may be helpful. It's good when you have validation. So if we've done studies like in DSRCT to show that Natera even picks up anything, then it can help us determine if it's a good test. The problem is that it hasn't been tested for every single type of sarcoma. So this is one where I would say that if you're interested in getting that test through your provider, it'd be good to talk to them about it and see if it makes sense. I wish these types of tests were validated for all sarcomas, but unfortunately it's still a work in process.
Okay, thank you. I think we have time for one more, and then there will be a couple left in there, Dr. Conley, if you have the time and are available.
Sure.
Okay, from a basic understanding, immunotherapy helps the immune system target and eliminate malignant cells. Why is it typically reserved for unresectable or metastatic disease? Couldn't it be beneficial to use it in earlier stages of cancer, possibly alongside conventional treatments like surgery or radiation to improve outcomes or prevent recurrence?
Yeah, I totally agree with that. Honestly, it just comes down to how quickly we get the testing done in what we call localized disease or early stage disease. And the way drug development works is that usually we have to start with patients, unfortunately, and I don't mean this in any bad way, but if you've had if you're someone that's already had a lot of standard stuff, oftentimes clinical trials may make sense, right? Because you've already had standard medicines, right? So this is, I need something else. The trials are available. So once we establish that there's benefit in that population, then we try to move it up. So oftentimes it's a matter of getting clinicians motivated to do this, getting companies to sponsor these types of studies, because unfortunately clinical trials are immensely expensive in the United States and to a certain extent in Europe. But the other factor is just once we get established. So Chrissy Rowland, one of the surgical oncologists in the Anderson, actually published a study. It was in Nature Cancer earlier this year. It was the first neoadjuvant trial with immunotherapy plus or minus radiation for patients that had undifferentiated pleomorphic sarcoma. And so it was what we call proof of principle sort of study. It was a pilot study. We wanted to see if giving immunotherapy with radiation in patients that had localized UPS would benefit, at least in terms of certain parameters that she was looking for. And it did. It was very interesting. And so that's why it got presented and published. And more importantly, the organization known as SARC had the SARC 032 study that was just presented at ASCO this past year, not published yet, but it was a trial where patients with localized UPS basically got either radiation followed by surgery, or they got radiation plus immunotherapy followed by surgery, followed by more immunotherapy. And in that study, the progression-free survival has been found to be superior, statistically significant compared to those patients that didn't get the immunotherapy. But now it's kind of like we're all sort of like figuring out, what do we do? They didn't test chemo either, so how do we know how it compares to chemotherapy? So the answer is that we are definitely trying to get it earlier. I think what you're thinking about makes a lot of sense. I mean, if it works with metastatic disease, why wouldn't it work for localized? I think it could. But it's just a matter of getting these studies done so that way we can hopefully change the way we care for patients.